a challenge to dignity. Our goal was to link academics, activists, and agencies concerned with the health of refugees and asylum seekers in a spirit of collaboration and comparison, bringing together professionals working with different populations of forcibly displaced peoples, ethnic groups, and nations. The video you are watching will contain an individual presentation edited to stand alone. We hope you find them to be of value.
Our final presenter is Dr. Tala Al-Rousan, who is an assistant professor in the School of Public Health here at UC San Diego. She is also worked as a volunteer physician with Doctors Without Borders and with the Syrian American Medical Society. She conducts work to improve the health of refugees from the Middle East and Afghanistan. And her title is Refugees on the Move, Health Along the Migratory Route Between Syria and California. Tala.
Being a refugee is much more than a political status. It is the most pervasive kind of cruelty that can be exercised against a human being. You are forcibly robbing this human being of all aspects that would make human life not just tolerable, but meaningful in many ways.
The more immune you are to people's suffering, that's very, very dangerous. It's critical for us to maintain this humanity.
الان 60 روزه با پسرم همینطوری داریم میچرخیم، ولی هیچ کس نیستش که بگه یه راهی رو بخواد به ما نشون بده. کجا برم زندگیمو شروع کنم؟
If children grow up without any hope, without any prospects for the future, without any sense of them being able to make something out of their lives, then they will become very vulnerable to all sorts of exploitation, including radicalization.
ليش انتوا هنا اليوم؟
طشة الفصل المنفذ الوحيد في غزة، في السجن الكبير غزة، مش في غزة، سجن كبير يعني.
The officials came here and told them, look, there's no way you're going to get papers to continue. Either you go voluntarily or we arrest you.
I respect you. I respect the passport and I respect you.
It's going to be a big challenge to recognize that the world is shrinking and people from different religions, different cultures are going to have to learn to live with each other.
I hope you guys have some energy left in you. After the last presentation, I'm hoping to shift gears a little bit to talk about a story of hope, hopefully, in some way moving forward, thinking about this global crisis. So just a reminder, since some new people are joining in from online and here with us today, I have Moj and Banan here, who are my research assistants, refugees from Iraq and from Syria, perfect rock stars who have been working with me for the past 3 years to start some initiatives here in San Diego. So just a reminder, we have never seen these numbers before in the world, right, of refugees and people who are forcibly displaced. We are at 82.4 million people who are displaced, and of those, about 27 million are believed to be refugees. There are 4 million people who are stateless, right? Just living completely on the margins of society. Now, 2/3 of the world's refugees, all the world's refugees, come from 5 countries. Those are Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. We know that there are raising inequalities, especially with the pandemic now. We're sitting in a state here in California where a few people are controlling the majority of the global wealth, right? The entire wealth of the world. We know that the pandemic has increased their wealth while also has increased a lot of suffering for people and displacement. We know also that climate change is real, and we feel it here in the United States, and we feel it also in different parts of the world, especially in the Middle East, where I come from, where there's a huge drought problem and extreme weathers. Raising conflict all over the world, so more and more people will be displaced. So these numbers are expected to keep growing. And this is just to map out the world's refugee population. So the major producers of the world's refugees, Syria, Afghanistan, Venezuela, Myanmar, Somalia, South Sudan. However, most of the global refugee burden is borne by the global South, countries like where I come from, Jordan, that are limited in resources themselves. So let's keep that in mind, that most of these refugees live in parts of the world that are struggling themselves. This is also a reminder to all of us and has been discussed before in other talks, but this is the socio-ecological model of health. That's how we think of health. It's not just, your age, sex, hereditary factors, it's so many other things. And migration cuts across all of these layers. So really migration is a social determinant of health. And in my opinion, it is completely understudied and not looked at as a real determinant of health. It's also important to say that when we research refugees, we should think of all of these, the place of origin, what happened to them before they took their journey, what happened during travel and transit, their place of destination, and whether they will return or not. So keeping these kind of cross-cutting aspects also is very important in conducting research with refugees. So the title of my talk is really thinking about migration or displacement as a dynamic process. So what I'm hoping to do, and what we've seen from other presenters, that a lot of the refugees that stop in Jordan, a country so far from here, end up here in San Diego. So our research should somehow compare and start thinking of it as a dynamic process, right, along the migratory route. So if we think of refugee health research, including all of these aspects, I think we can produce better research. This is a picture of Damascus in 2009. This is where we used to go for dinners and lunches, beautiful food. So Damascus is believed to be the oldest continuously inhabited city in the world. That dates back to 11,000 years. It was beautiful. In 2011, these are the pictures we're seeing from Damascus. I forget a lot, and I'm only 41, so why am I so forgetful? So I really started looking at the literature, seeing whether displacement and trauma related to displacement increases the risk of dementia. There was almost nothing at all in the literature. So I felt as a healthcare provider, I am not able to give her the answers she seeks. And that's why I started shifting my career more towards research and thinking, how could we as epidemiologists, as healthcare researchers, help these populations through science? So again, thinking of migration as a dynamic process and these mobile populations moving across the countries. So we have here Morgan, who's going back and getting some stuff from refugee families back there. And when she comes back, she does the same thing. Also thinking about health the same way. These people are mobile populations. I have almost not encountered a single refugee who didn't want to return back to their country. They almost all say, we wish we could return back to Syria. We wish we could return back to Iraq. So hoping that more comparative studies between both locations could tell us something about the health of these mobile populations. So we have some research in Jordan that is looking at health needs of older Syrian refugees in camps and outside camps. So they're very different populations. Those who live in refugee camps are usually poorer. Those who cannot sustain living outside, they're usually sicker. They don't have access to employment, right? And they don't have a perfect access for education. There are some schools, primary, elementary schools, but those who live in the community have different needs as well. They don't have the access to healthcare the same way it is in refugee camps, where things are more contained, where NGOs kind of offer more help, and it's easier to access those NGOs. So very different needs for refugees in camps versus outside camps. I am also trying to answer that question, whether mental health trauma impacts cognition over time. This is a question that hasn't been researched. And I think in the context of the Syrian crisis, this would be a very interesting question to look at, since the type of trauma that this population has endured is severe, and it's sudden, and it happened recently. So we are able to follow these people over time. Finally, here in San Diego, I'm hoping to look at implementation science. So taking interventions to the community of refugees and seeing whether it works or not. So this is a little bit different than the epidemiological cohort study that is going on in Jordan, but also experimenting with how a population of refugees here would accept a culturally sensitive implementation project, given that a lot of my team are refugees themselves and are embedded in the society here. Finally, we're also looking at COVID-19 impact on refugees, and I'll share with you more of this particular study's results. So I've had some early research with similar populations before, the population of the prisoners population. I did research of mobile home trailers. I did research for the homeless population. And I'm always thinking about institutionalization, right? So I'm thinking of detainment, containment. How does that impact brain health? How does that impact different health outcomes? So there are a lot of similarities between these different populations. And I just wanted to point out that, a lot of us, seeking grant funding, et cetera, I get from grant reviewers, but the refugee population, how many are there out there? So what I want to say is that a lot of learnings that could happen from this population could be applied to other similar populations. So I'm focusing most of my research, how does displacement impact chronic disease management over time? We've learned a lot from orphanages about the performance of children who have lived most of their life in orphanages and how that impacts cognition over time. So I'm hoping to do the same thing in the Zaatari refugee camp. The Zaatari refugee camp is truly a village on its own. So you can't see the end of it when you walk inside. And there's a lot of innovation there, restaurants going on, wedding venues, life goes on, even if it's a refugee camp. However, now that we're conducting a lot of our interviews, like I talked to Catherine the other day, the words, there are some certain words, like feeling like I'm in prison, feeling like I'm pressured, feeling like I lack freedom, although I'm able to walk around. So, a lot of the research, again, is trying to see what are the aspects of encampment or institutionalization that impacts one's perception of health, and thus their health behaviors, and thus their adoption of different health interventions, right? Because it's highly, highly interrelated. So this is a map of Jordan, and many of you might not know this, but Jordan is the second largest refugee resettlement country per capita in the world. So 1 in 3 people in Jordan is a refugee. Historically, it was called the East Bank, and Israel-Palestine was the West Bank. So Jordan has been formed as a country to receive a lot of refugees, historically from Palestine, Iraq, and as you can see, all the neighboring countries of Jordan are countries suffering from conflict in a way or another. And this has been mentioned also in some of the talks before, but about 85% of Syrian refugees live outside camps. So they speak the similar dialects to Jordanians. They're embedded in the community, while 15% live in refugee camps. This is our publication with the WHO East Mediterranean Journal, really characterizing the different health needs of refugees, those who live in camps versus those who live outside camps. This was the first paper to really start thinking about, those who live in camps, what kind of needs would they have compared to those who live outside camps? Many of them are mobile too, right? So they leave during the day to work outside, then they come back to the camp. They spend their weekends in the refugee camp. So we did a mixed method study and really thought about the health priorities from the perspective of refugees for those inside camps versus outside camps. And this is Dr. Bernard Lamb at Harvard, who is my mentor and who supported this work. And I like to always remember his quote here: "We physicians who shepherd human life from birth to death have a moral imperative to resist with all our being the drift toward the brink. The threatened inhabitants on this fragile planet must speak out for those yet unborn, for posterity has no lobby with politicians." These are some images from our research. As you can tell, there's a males group and females group, so we kind of interview both. This is an aerial image of the Zaatari refugee camp in Jordan.
Tell us, step closer to the microphone.
Oh. So now taking you back to San Diego here. Many of you might not know this also, but San Diego is a large refugee resettlement hub, one of the largest in the country. There was a US Immigration Policy Center here that produced this report showing that a third of San Diego's essential workers were immigrants, and that the fastest growing foreign-born populations here are from Syria, Kenya, Sudan, Iraq, and Nigeria. We continue to be resettling the largest number of Syrians in the country here in San Diego. And now we're expected to resettle one of the largest amount of Afghanis too.
2 minutes, Tella.
Okay. Just the story of what happens to refugees when they come here. So they arrive at the airport here in San Diego. The HHS, the Office of Refugee Coordination, whom you've heard from during this conference, takes care of them for 30 to 90 days only, basically screening them, connecting them to different services. And then those refugees are sent to certain enclaves here in San Diego, El Cajon, City Heights, where 23 to 30% of all residents in those areas live below the poverty line. The majority of refugees who live here are East African or Middle Eastern. However, the social fabric in San Diego is very unique in that, as you heard also during this conference from the San Diego Refugee Coalition, they formed a group of ethnic community-based organizations that came together and thought, okay, now these refugees are left on their own to navigate a whole country, a whole system. What can we as NGOs, ECBOs, what can we do? And then the Family Healthcare Center of San Diego is the main health providers. It's not us at UC Health here. It's these federally qualified healthcare centers. There's no tertiary care, so it's primary care. And we are now researching a lot of the issues that they're facing in terms of working with refugees. So a lot of the cultural insensitivity, language barriers that come up, transportation barriers, those are all now we're trying to characterize in our research. Another question that came up, CVD, cardiovascular disease, how does it impact refugees? Or are refugees at higher risk for developing cardiovascular disease just solely because of being refugee? That's a question that has not been answered. So we recently conducted this meta-analysis to isolate the effect of displacement on cardiovascular disease and different risk factors. And we saw that, yes, being a refugee only after you adjust for so many other things does impact your risk of CVD. So you are at a higher risk of developing cardiovascular disease if you are a refugee. Now, the main project that we're conducting here in San Diego that Benin and Mauj are part of, we are teaching refugees how to measure their blood pressure at home and keep track of their measurements in a diary. And we're seeing whether they like doing this or not. So basically taking healthcare to refugees' homes, since a lot of the barriers that they deal with have to do with language, transportation, not feeling welcome at the healthcare setting, not having somebody to navigate care with. So we're basically taking the technology out there by having them wear connected blood pressure monitors so that their providers can see their readings and make decisions related to healthcare, to medications based on these readings. This is a study looking at the impact of COVID-19 on the community. So in partnership with the Partnership for Advancement of New Americans, PANA, which is one of the ECBOs here, we conducted the survey by phone just to kind of have an understanding of what's going on with the pandemic here with the Refugee Society. So we surveyed 191 African refugees and about 258 Middle Eastern refugees. As you can see from this demographics table, most of these refugees don't own their home. They're renting their homes, okay? Most of them are living in economic hardship. Many of them are unemployed. Most of them don't speak English at home. Most of them have children. Okay, this is just to tell you, we asked them if they're bothered by emotional problems, and 47% of them said yes. We also looked at aspects of COVID-19 stress, community stress that are really correlated with that. And for the African refugee community, it was that families are unable to get cash for daily expenses. They can't have enough food, and their children are unable to continue their studies at home. For Middle Eastern refugees, they are reporting more violence in the household because of the pandemic. And they were also reporting that people are becoming more anxious and depressed in their household. Those all correlated with their own mental health. Finally, I just think, leaving on a positive note, I think there is a lot of room for innovation, opportunities. Clinical care, we can do a lot for clinical care. Trauma-informed care, more cultural sensitivity, kind of thinking of a model where community health workers can be embedded and refugee-focused. They can be refugees themselves. Many of the physicians that have been physicians before and are displaced can work as community health workers. Advocacy should be multi-layered, cross-sector, equity, social and political determinants of health, justice, innovation, and team-based care and policies. These are our collaborating organizations and us doing research here. And thank you. Thank you.
Well, I think that you were right. You were ending on a positive note, a note of hope. Placing you last on the agenda, I didn't have that intention because I didn't know what you were going to say, but it's a wonderful serendipity. And I think one of the best places to leave us is just to reiterate the last things that you had on your last slide: clinical care, advocacy, equity, justice. If we have those things, and if we encourage those things and promote those things, all of our work will not be in vain. And that includes the energy we've put into the last 2 days. So strong ringing endorsement of those 4 points.
I have a question. I'm so thrilled to see your science and all the ways in which you are leading. And it just makes me think about how do we get more people from a refugee experience on the pipeline to being leaders and being, at the table setting the research agenda. And, what are the barriers and facilitators? What can you tell us about that so that we can diversify, who's really in the lead here? Because I think people like you are the future. Thank you, Teresa. So I have Moj here, who has been a rock star, 2 times refugee herself from Iraq. And she has really helped us shape everything. She has taken on this job with a lot of passion. And she's now applying for a residency to become a family medicine resident. And she was looking for a research experience. She reached out to us, and Moj has been a rock star and has helped us a lot. So I think, Teresa, being deliberate in who you hire is really key. And I think there are a lot of assets out there and a lot of refugees that are looking for opportunities to be part of this, to shaping their own narrative, shaping the research that's being done with them. So, being deliberate in how you present them on the leadership, not just on collect data or do things, but really, how do you grow so that you become a physician and carry on this experience with you? Or if you stay in the academia and want to continue a career as a refugee, surfing refugee yourself, how do you lead forward? And that's what we're trying to do here. So I want to always emphasize that, please, if you can, put them in leadership positions, they are the best to carry this mantle.
Can I just say a comment? I want to agree with you. You touched on the same point that I was talking about, dignity and giving refugees, a lot of power to do things, and how they feel low self-esteem because of the loss of status. They were doctors or engineers or successful students in Iraq or Syria or other countries. And it's good to give them a chance, and the dignity and how their self-esteem would improve tremendously if given a chance. And they're very hard workers and they could do a lot. I agree with you.
Not just give them a chance, but make them instead of you.
Yes.
Having the humility, the professional humility to really understand
that
nobody understands someone's pain unless they were in that
position. That's true.
Final question. I was just wondering if you're looking at the suffering and memory loss with different populations inside camps, outside camps.
Yeah, so that project that we didn't talk a lot about, that's looking at mental health effect on cognition, we are really looking at exactly that. So we're looking at PTSD, anxiety, different mental health outcomes or exposures, and we're testing cognition using a tablet. So really through MoCA also, which is a battery used to test cognition. So yes, we are looking at that, and that's a huge study. That's a cohort that we're building. One of the things also that is lacking in refugee health is the longitudinal research. Most of the research on refugee health is cross-sectional, meaning you take one snapshot time at what's happening, and then you leave and carry on in another location, another project. So I'm kind of really hoping to continue with the same group over time so that we are able to have a better, cause-effect relationship and be able to comment on a lot of those. Thank you.
I want to add just a brief comment. Thank you so much for your presentation. It's so interesting and valuable. And also to acknowledge you being involved as refugees in all this process. And I was thinking about some migrants that in the Mexican side, a few of them that are interested on being lawyers just to fight for migrants' rights as well. And I was thinking in your experiences, if the experience of being a refugee was something that transformed your life project, something that you became interested on, being involved on these issues after being refugee, and which were the opportunities. I was thinking about a specific girl in Tijuana that after giving her testimony in different panels, was offered a grant to study law in a private university in Tijuana.
nice.
So it was a result of being like voicing other migrants.
Right.
And I wanted to know like the way you became involved and the opportunities you found.
Right. Right. I don't know, Moj, if you'd like to speak about your own experience and how, your career kind of led you to this work, but I can speak about my own. I'm a daughter of refugees, and there was not a single day on the dinner table that we didn't talk about that, lingering to going back home and how that impacts different things. My dad, his parents were from Syria, and he moved when he was a little child as a political asylum seeker to Jordan. And he would always, he's hypertensive, diabetic, and he doesn't take his medications on time. So I'm like, Dad, you need to keep up with your medications. He's like, life is not worth it, after what's happening to Syria and not being able to go back. So as a physician, I couldn't help but think of, again, the trauma and the baggage that patients carry with them and how that impacts their health decisions. So when I became a physician, I was also morphing very slowly to, again, the struggle of mine trying to answer questions of my dad's situation. Why isn't he taking his medications? Is it really related to what happened to his parents and his ancestors and what he's carrying with him? So yes, personal experience do play a big major role. And it makes you not want to quit. I was, again, in my career, my professional career, I was always pushed to do something else, but I would keep coming back and try to get funding and try to work on refugee health, because I know that there's a huge research gap. Maybe it's not a topic of interest to many donors or etc., but actually there's a huge need to do something in that field. And if done, with minimal efforts, it could have implications to global populations, to millions. So yes, personal experience play a major role. It's just having the right mentorship, the right opportunities at the right time. All of those play a major role.
I just wanted to say, in terms of memory loss, all the clients that I worked with that experienced trauma, they all suffer severe memory loss. So it definitely is a contributor, the abuse and the trauma definitely affects memory, yes.